So what is the clinical scenarios of anterior ischemic optic neuropathies? Anterior ischemic optic neuropathies tend to occur in older age population. Like in 40 to it's first subdivided into anterior non-arthritic ischemic optic neuropathy or NION and anterior arthritic ischemic optic neuropathy or ION. So what will be the difference between the non-arthritic and arthritic? Both of them occurs due to ischemia of the optic nerve. And both of them occurs in older age population. However, the non-arthritic ischemic optic neuropathy tend to occur at younger age group. It tends to occur at between 40 to 65. I'm stressing on that because these are the frequent areas that are asked in the clinical exams, in the MCQ exams, and also will help you to interpret the scenarios so that you will know what will be the clinical scenario points to which disease entity. So the demography here is very important. 40 to 65-year-old, this patient, it is males equals to females, and if younger, consider vasculitis. Like if you have a patient with ischemic optic neuropathy and the scenario says that this patient is 35 or 40-year-old, you may consider that this patient has vasculitis that will cause this ischemia. So what about the onset and course duration and the presentation of this disease? So it is usually unilateral. If it is bilateral, again, can be bilateral, or the other eye can be involved later on. If you didn't control the risk factors, those patients present with sudden dramatic onset of loss of vision with a stationary course. So sudden onset, stationary course. And those patients usually report that this happens, especially when they wake up in the morning, like because when they are sleeping, there is like venous stagnation, and this venous stagnation may cause hyperviscosity, causing occlusion of the blood vessels, causing infarction of the optic nerve. So this is very characteristic to come to you in the clinic in the morning and say that I cannot see. So what are the risk factors? For the non-arthritic ischemic optic neuropathy, the risk factors are the vasculopathic risk factors for atherosclerosis, like if the patient is hypertensive or diabetic or a smoker or hyperlipidemia, or there is very common scenario where the patient received the sildenafil. The sildenafil or the Viagra will also can precipitate ischemic optic neuropathy or anterior non-arthritic ischemic optic neuropathy. There is also what's a term which is called a small crowded disc or optic disc at risk. So for those patients who have a very small optic disc, like is anatomically small, they will have a very crowding of the blood vessels at the surface of this optic disc. This will result in that they will be more liable for infarction, resulting in the ischemic optic neuropathy. So it was found by trials or ischemic optic neuropathy trial that many patients who were enrolled in this trial, they will have a small disc at the start. So they have this small disc is called the disc at risk. Those patients usually can present with history of transient ischemic attacks or amaurosis fugax. So they have transient loss of vision that comes and goes. This is because of showers of emboli from the internal carotid artery that is occluded by a theroma. So it will cause them transient ischemic attacks and amaurosis fugax. And finally, one of these emboli may impact it into the branches of the posterior ciliary arteries, causing the ischemic optic neuropathy. Those patients will present with sudden loss of vision and there is absent pain. Regarding the signs, those patients will present with a relative afferent pupillary defect. So they will have, again, the full picture of the impaired optic nerve functions. They will have a relative afferent pupillary defect. They will have affection of the color vision, which is proportionate to loss of vision. So here is the differentiating part between it and the optic neuritis. Here, the patient will have severe and massive loss of vision, and also will have severe and massive loss of color vision. So both of them are proportionate. When you check the fundus of those patients, you found that there is a sectorial pale disc swelling. So the disc swelling usually take a sector. So you can see here it is taking the upper sector. And there is blurring of the disc margin. The lower disc looks like more normal. And the striking feature here is the disc at risk. You can see that the disc is very small. And there is a very crowding of the blood vessels. Okay. And there could be like splinter-shaped hemorrhage also present here. So this is called a disc at risk. And this is how does the optic fundus appears in those patients. Dr. Islam, the pale disc hyperemic or pale start first in the acute attack is becoming hyperemic, then later on become pale. For the acute attack, become hyperemic, then later on, after just a few days or 2 weeks, it becomes pale. Let's now talk about investigations. If we are suspecting a patient with anterior ischemic optic neuropathy, and we want to investigate, how would we do investigations? First of all, we need to differentiate, or the main differentiating feature or the main differential diagnosis at this age with this presentation will be the ischemic optic neuropathy or the arthritic ischemic optic neuropathy. In order to differentiate, we can do the fluorescein angiography. The fluorescein angiography can show moderate leakage present at the disc margin, and the important feature here is the normal choroidal filling. This is asked even more and more every year in the ICO exams, which is the choroidal filling. The choroidal filling, you can see that the patchy choroidal filling in the fundus background is present here. I know that we didn't discuss the fluorescein angiography yet. We will discuss in the retina lecture, so just bear with me. We will come to that later on. But those patients have normal choroidal filling. When I'm going to show you the arthritic picture, you will know the difference. The visual field, it will show the altitudinal visual field loss. So this is very characteristic visual field loss for those patients, and also asked frequently in the exams. What is the most common visual field loss for anterior ischemic optic neuropathy? It will be the altitudinal visual field loss. And then we do laboratory. What is the aim of laboratory tests? We have two main aims. The first one is to exclude the very serious giant cell arthritis, the very serious anterior arthritic ischemic optic neuropathies. So we do ESR and C-reactive protein to exclude this disease, as we are going to see the next one. Then also we do CBC or a full blood count in order to exclude case of thrombocytosis or to exclude any abnormality in the blood film or in the blood picture. So also this is important. And then we do the vasculopathic risk factors workup, like to measure the blood glucose, to do the hemoglobin A1C, to do lipid profile, do cardiovascular workup, like to do carotid duplex, to do echocardiography, ECG, and refer this patient for a cardiologist in order to detect the cause. So we are now trying to control the risk factors. So we know what will be the cause to what. So if this is what will be the aim, I'm going to tell you in the next slide. Also, if those patients are young, you can do vasculitis screen to detect what will be the cause. So those patients can have antiphospholipid syndrome and other protein C deficiency, protein S deficiency, wide variations of syndromes and vasculitis disorders that can result in ischemia or can result in ischemic optic neuropathy in young age. So what will be the cause or the rule of treatment? The rule of treatment is to control the risk factors. And so as there is no effective treatment for non-arthritic ischemic optic neuropathy. So for those patients, there is no treatment that will recover the vision. And the aspirin, according to the trials that were conducted, that the aspirin, when they were given to patients with patients with non-arthritic ischemic optic neuropathy, and they were compared to other groups who didn't receive aspirin, there were no statistical difference in the final visual outcome. So the aspirin may have a role to control the risk factors, but not a role to improve the visual acuity. So this brings us to the prognosis. Those patients with anterior ischemic optic neuropathy, what will be the fate? Do they will have persistent visual loss? Well, no. The good news is no. That the vision will worsen over the 2 weeks and then stabilizes by 2 months. And 43% of those patients will gain the 3 lines or more after 6 months. This is the result of the ischemic optic neuropathy decompression trial. So this trial compared the patients who didn't receive anything or didn't receive any treatment, and those who received the steroid, and those who received the surgical decompression. They found that those patients who we just observed them, by just observation, they did better. 43% of patients by just observation gained the 3 lines or better after 6 months. So we can reassure those patients that although that there is no treatment, but some of them may show recovery already. The last part, or the last ischemic optic neuropathy, is the anterior ischemic optic neuropathy due to giant cell arthritis, or arthritic ischemic optic neuropathy. This is a serious disease. It is a systemic disease, necrotizing granulomatous inflammation that is affecting the medium to large size arteries, and typically affect the older age population. So if a patient presents with sudden loss of vision, he is more than 70-year-old, and then this is a giant cell arthritis until proved otherwise. This is very commonly, frequently asked in the exams, and also encountered in practice. So just bear in mind that giant cell arthritis is a very important and serious disease to consider in elderly population. It is more common in females. So in contrast to the non-arthritic ischemic optic neuropathy. And for those patients, it tends to be unilateral, but the other eye can be involved later. And that's why also we need to protect the other eye. Those patients will present with sudden dramatic onset with a stationary course as well. So the clinical presentation here is very important also to note. This is what will you see in the scenario. Those patients, like around 30% of those patients, will have history of polymyalgia rheumatica. This is a very common association to those patients. Those patients having weakness and pain all over their body, especially affecting the large joints. So, and usually they are on a steroid treatment. So once they stop the steroid treatment, they develop the giant cell arthritis, the arthritic ischemic optic neuropathy. So they will present with sudden loss of vision, with pain, and there are some characteristic signs like scalp tenderness. When the patients try to comb her hair, she experiences pain, scalp tenderness, jaw claudication. Those patients have ischemia of the masseter muscles. So when they are trying to chew something or swallow something, they will experience pain with the jaw claudication. They will also experience proximal myopathy, weakness of the proximal muscles. They cannot dress themselves up. They can also present with weight loss, present with malaise. So all these symptoms are present in patients with anterior ischemic optic neuropathy of the arthritic type. So these are the symptoms. Regarding these signs, when you check those patients, you will find that there is profound visual loss, there is severe visual loss, and there is impaired optic nerve functions. So they will have a relative afferent pupillary effect. They will have also color visual loss, which is proportionate to the visual acuity loss. Look at the fundus. They have what's called the chalky white optic disc edema. There is disc edema, there is blurred margin, there is obliteration of the cup, and there is engorgement of the veins, and there is chalky white. It is white disc swelling. And also, these patients can present with what's called the other manifestations of the giant cell arthritis. Giant cell arthritis can cause occlusion of any artery, like ophthalmic artery occlusion, like ciliary artery occlusion. This patient has ciliary artery occlusion. So a cilio-retinal artery occlusion. They can have a central retinal artery occlusion, branch retinal artery occlusion. So all these manifestations can be present in patients with giant cell arteritis, not only the visual acuity, but it will be all, or not only the ischemic optic neuropathy, but also other ischemic affection of other arteries. So this is regarding the fundus picture. What are other important signs? There are some important signs in the general examination of the patient. So this is the temporal artery, the superficial temporal artery. This patient who had temporal arteritis, you'll find that the temporal artery is thick and palpable and non-pulsating and tender and appears like a cord-like. So when you are palpating it, you will find it again. It is thick, it is tender, it is non-pulsating, it is cord-like temporal artery. So this is very important because we will need that later for to confirm our diagnosis. Also, those patients can have ischemia of the extraocular muscles, so they will present with diplopia. So let's say that I found now the history, the signs, the symptoms of a patient with anterior ischemic optic neuropathy. What will be the next step? I need to confirm my diagnosis. So I need to confirm my diagnosis by laboratory. So the laboratory here is the initial investigations. When I'm suspecting a patient with giant cell arteritis, I am doing ESR, C-reactive protein, and the CBC in order to detect these are the ESR and this should be ESR and C-reactive protein. This will be in order to confirm the diagnosis of the or to raise the suspicion of the arthritic ischemic optic neuropathy. These are acute inflammatory, acute phase reactants. So they will increase in case of inflammation. So if I find that the CRP is increasing and ESR is increasing and the CRP is more sensitive, so I'm together with the symptoms and signs of giant cell arteritis, this will be very highly suspicious of giant cell arteritis. So this patient should be admitted. So why this patient should be admitted? This patient should be admitted for treatment by a pulse steroid therapy, as I'm going to say now, even before confirming the diagnosis. So the pulse steroid therapy will start, then we can order the confirmation of the pathology. So how can we confirm the diagnosis? We can confirm by the histopathological assessment, by doing taking a specimen from the temporal artery biopsy, from the temporal artery. So this procedure is called temporal artery biopsy. So for the temporal artery biopsy, when we are taking it, we are examining under the microscope to find the clues for granulomatous inflammation. So this should be the normal section of an artery. This is the endothelium, tunica media, tunica adventitia. In case of giant cell arteritis, you can see the massive thickening of the artery. The thickening of the media at the adventitia. There also will be what's called fragmentation of internal elastic lamina. And there will be occlusion of the lumen. You see this narrowing of the lumen, this is what will cause the infarction of the optic nerve. And we can see that there are granulomatous inflammation. There will be granulomas present or granulomatous giant cells present in the wall of the artery. An important thing here also while taking the specimen is to avoid what's called skip lesion. So you need to take a lengthy part of the temporal artery in order to avoid what's called skip lesions. These skip lesions can give you a false negative results. Regarding the fluorescein angiography, you can see this is the fluorescein angiography. This is what I was telling you about the blocked or the absent choroidal filling. This is because of the thrombosis of the short posterior ciliary arteries. This is which are originating from the ophthalmic artery. So these are actually the pathology of anterior ischemic optic neuropathy is that there is inflammation. This inflammation causes thrombosis of the short posterior ciliary arteries, which fills during the choroidal phase of the fluorescein angiography. So they will show this lack of fluorescence. You can clearly compare between the temporal and the nasal part of the optic disc. So this is also appeared earlier in the clinical ICU exams, and it's also very important clue to differentiate between both arthritic and non-arthritic. There are other recent modalities about the diagnosis of the optic neuropathies or arthritic ischemic optic neuropathy, such as MRI. So MRI has recently showed like evidence to differentiate between arthritic and non-arthritic ischemic optic neuropathy. So it will show like a bright spot for those patients with arthritic ischemic optic neuropathy. So it can be used, and also the ultrasound duplex or ultrasound on the temporal artery. So this duplex or ultrasound can measure the flow within the temporal artery and show the characteristic dark wall swelling, or what's called the halo, for patients with joint arthritis. Okay. Dr. I don't know what is your name, but why there is absent choroidal filling? As I told you, that those patients had the choroidal filling occurs from the short posterior ciliary arteries. So these are the arteries which are representing the choroidal circulation, or share in they are fill in the choroidal circulation, or fill in they are branches from the choroidal circulation, and they supply the optic nerve. So once they are occluded in giant cell arthritis, they will not supply the optic nerve, and they will also not supply the rest of the choroid. So this part of the choroid is coming from, or the filling of the choroid is coming from the short posterior ciliary arteries, which are occluded in the giant cell arthritis. And this occlusion by inflammation. Okay, clear? Okay, I will share you in the group the question that appeared in the clinical ICU before. So I will just give you like a short video for the question itself that appeared in the clinical ICU. So now you investigate and confirm it. And even before confirmation, you need to start the treatment. As long as the symptoms and signs point to giant cell arthritis, you need to start your treatment. So what will be the treatment? The aim of treatment is to protect the other eye, because actually the other eye has a risk of development of giant cell arthritis as soon as 24 hours. So this is very risky disease, and this patient can be blind, and you have a responsibility to protect him from this destiny. So you need to recognize it and treat it. So treatment can be inducted by intravenous methylprednisolone. So when the FRCS3 course, we say that what we should do workup, or so I'm here not trying to approach a patient, but just to summarize the important points about the clinical MCQ exams. But it will be the same thing, but it is not like an approach type of approaching the case. But if you wanted to approach it, we will start this patient we do counseling with the patient. We should work up for steroid. We do measure the blood pressure, blood sugar, refer the patient for internist to assessment for if there is any peptic ulcer, if any history of tuberculosis, and also if there is any osteoporosis, and refer this patient also for rheumatologist, for cardiologist, for co-management, because this patient are at risk of development of renal failure, heart failure, aortic aneurysm. So and together, if this patient has polymyalgia rheumatica, this should be managed by a rheumatologist. So this is a team management for the same patient. But now I'm speaking about the ophthalmological management. So for those patients, you should receive pulse steroid therapy by intravenous methylprednisolone every 6 hours for 3 days, then oral prednisone for a maximum of 60 to 80 milligrams per day, which is also 1 milligram per kilogram per day. After 1 month, we taper by 5 milligrams per week using the patient's symptoms and ESR as a guide. So it should be less than 20 millimeters per hour. And those patients will be continuing on maintenance dose of steroids, oral steroids, of 10 to 15 milligram for around 2 years. So this will be the management of patients with anterior ischemic optic neuropathy or arthritic type. And an important thing that I just forgot to tell you that when the temporal artery biopsy is not positive, or if it is negative, and we still have a strong clinical suspicion of giant cell arthritis, we can take biopsy from the other side. And if it is still negative, we can even continue the treatment if the patient's symptoms and signs are improving and the ECR and C-reactive protein are normalizing. Okay. Finally, the prognosis. So the prognosis, what will be the prognosis? For those patients without treatment, the visual loss is 45 to 95% of giant cell arthritis patients, typically within 4 months. So this is a very devastating fate. Actually, those patients very poorly recover the visual acuity, like only 15 to 34%. And the rule of treatment or the treatment can be higher, or the incidence of improvement can be a little bit higher for patients on treatment or intravenous steroids. However, we shouldn't make great hopes on that, but actually the main purpose of the treatment to protect the other eye rather than improvement of the vision of this eye. However, in this patient, unlike the patients with optic neuritis, we said in optic neuritis we can give the treatment or we cannot give. Eventually, the patient will receive will reach the same visual acuity. But here it is crucial. It is not the same. It is not the same urgency. It is more urgent here in cases of giant arthritis, because of those. If those patients are left untreated, the bilateral visual loss may proceed quickly from either optic nerve, retinal, or choroidal ischemias in up to 50%. So as I told you, those patients can have ocular affection in many ways. They can have ischemic optic neuropathy, they can develop retinal artery occlusion, central retinal artery occlusion, branch retinal artery occlusion, cilio-retinal artery occlusion, ophthalmic artery occlusion, ocular ischemic syndromes. All these can present also in patients with giant cell arthritis. So to summarize, the ischemic optic neuropathies, it will be different entities. You have non-arthritic ischemic optic neuropathy, the arthritic ischemic optic or arthritic ischemic optic neuropathy. There is also an entity called posterior ischemic optic neuropathy and diabetic papillopathy. For non-arthritic ischemic optic neuropathy, it's more common in old age. It is always remember the disc at risk, remember the hypertension, diabetes, hyperlipidemia, and erectile dysfunction medications, and the sectorial disc swelling. These are, and the altitudinal field defect. So these are the clues in the scenario that points to non-arthritic ischemic optic neuropathy. For arthritic anterior ischemic optic neuropathy, think of old age, older than the non-arthritic. Look for the giant cell arthritis clinical picture. Look for the pallid edema or the white disc swelling. Check for the ESR, C-reactive protein, temporal artery biopsy, cilio-retinal artery occlusion, ocular cranial nerve palsy. As it also ocular cranial nerve palsy can be one of the manifestations of arthritic ischemic optic neuropathy. In posterior ischemic optic neuropathy, it is another entity which is diagnosed by exclusion. In those patients, they have infarction of the posterior part of the optic nerve, which is the retroocular part. So they have normal optic disc, they have normal fundus, but they will have a loss of vision, usually after trauma or after surgery or after blood transfusion. So those are called posterior ischemic optic neuropathy. Diabetic papillopathy, it is those patients will present with a mild affection of the visual acuity. There will be, or sometimes no affection of the visual acuity. They are young diabetic patients and they will show disc surface telangiectasia, dilated blood vessels over the surface of the optic disc. Other entities of optic neuropathies, they are the compressive optic neuropathies. And the compressive optic neuropathies and infiltrative and traumatic and toxic nutritional and radiation and hereditary optic neuropathies, all these can be also present in a differential diagnosis of optic neuropathy. So you should consider them for all cases that we just mentioned. So what are the suggestive clues about each one. For compressive, it is usually unilateral. Those patients have unilateral visual affection. And also they have what's called the Hoyt-Spencer triad. What is the Hoyt-Spencer triad? Those patients can have triad of progressive visual loss, optic atrophy, and optociliary chance. So when you have a patient with optociliary chance, always consider that this process is chronic, like in chronic papilledema, chronic compressive optic neuropathy, like in case of meningioma, chronic primary open-angle glaucoma. So this will be one of this Hoyt-Spencer triad. Again, is progressive visual loss, optic atrophy, optociliary chance. These are this triad, which is suggestive of compressive. And by the way, the earliest sign also of compressive optic neuropathy is loss of the color vision. So loss of color vision is very sensitive in cases of compression, even before the affection of the visual acuity. Signs of orbital lesions, like if the patient has proptosis, if they have restrictive strabismus, or if they have diplopia, or if they have some lid signs such as lid lag in case of thyroid eye disease, or if the patient has choroidal folds, all this suggest that the patient has orbital lesion. So think of compressive lesion that you should do neuroimaging. And those patients can present with a central or diffuse scotoma, depending on which part of the optic nerve is compressed. So whether it's compressing the papillomacular bundle or other areas of the optic nerve. For the infiltrative kind of optic neuropathies, it will be present with unilateral or bilateral optic neuropathy. There will be history of lymphoma, leukemia, optic nerve glioma, or meningioma. So we will cover these kinds of tumors in the pathology lecture. Orbital infiltration apart from disc edema. So you will find the disc what's called lumpy, pumpy appearance. There will be irregular disc margin showing elevated areas, which will denote that there is infiltration of this optic nerve, which also can occur with sarcoidosis. Traumatic, the optic neuropathy, there will be history of trauma. Usually it is unilateral with ipsilateral signs of head trauma. Toxic and nutritional, it will be bilateral, symmetrical, and so this is very important. Like if the patient has bilateral symmetrical optic neuropathy, think always of any nutritional deficiency, think of drug intake. Those patients can have toxic or nutritional optic neuropathy. And so there will be bilateral, symmetrical, with history of toxic agent or nutritional deficiency. There will be dyschromatopsia. Those patients will have a severe affection of the color vision. And central or centrocecal scotoma, and I explained to you why those patients have central or centrocecal scotoma, because the papillomacular bundle will be the most thick, it will be the most metabolically active, so it will be the highly, it will require high nutrients, and it also will be affected more by toxins because of this thickness and this high metabolism. So this affection will result in central or centrocecal scotoma. For the radiation, there will be history of head or orbital radiation. So this will result in radiation retinopathy and radiation optic neuropathy. For hereditary optic neuropathies, it will be bilateral. The patient will have telangiectatic microangiopathy, especially in what's called Leber hereditary optic neuropathy. The patient will show what's called peripapillary telangiectasia. There will be heart and CNS problems, and the fluorescein will show no disc leakage. So this will be differentiating these telangiectasia from the new vessels on the optic disc. Genetical testing will confirm the diagnosis, and those patients as well can show central or centrocecal scotoma. So these are the main optic neuropathies that are asked in the exam. The most important one that are asked in each exam: the optic neuritis, the ischemic optic neuropathy, the compressive, the arthritic and non-arthritic, and the important other differential diagnosis that can be confusing, a little bit confusing, but you know now what is the keywords, the clue for each cause or each scenario. Okay. So I know that neuro-ophthalmology is difficult and it needs a lot of understanding and a lot of mental exercise, and it is mentally exhaustive. So we will stop at that level now, and we will continue the next lecture so that I will give you opportunity to study this lecture, to understand it and not to confuse everything with each other. And we will continue the next time with the remaining of the neuro-ophthalmology. So do you have any question for all what we have discussed?